Winsley sir ஒன்னும் வரல.
Winsley sir எல்லாரும் அங்க எல்லாரும் WhatsApp linkல இருந்து ஜாயின் பண்ணிட்டாங்க மேடம். பேனல் linkல இருந்து 1 minute ஜாயின் பண்ணிட்டாங்க.
ஆமா இல்ல அவங்க WhatsApp link ஜாயின் பண்ணிருந்தாலும் we can promote them.
அப்ப சுதாகர், Winsley, Rose எல்லாரும் அதுல ஜாயின் பண்ணிச்சு.
Just promote them to this. Winsley will come. Yeah. Hi.
Hi sir.
Hi Winsley sir.
Sorry, I'm muted. Good evening.
Yeah. You're audible. You're audible. Yeah. Audible.
Somebody has
Tirumurugan sir, ஆரம்பிக்கலாமா?
ஆரம்பிச்சலாம் மேடம், இதுக்கு மேல ஒண்ணும் இல்ல.
Yeah, I think Dakshayani, you can start off with a prayer.
இல்ல இது வந்து ஃபுல்லா இவங்க நர்மதா is going to conduct the ceremony. So அவங்களோட secretary for ID.
Yes ma'am.
Start.
Ma'am, Dakshayani.
Yeah ma'am, I'll do.
Yeah.
குழந்தை மருத்துவனின் இறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும். நோயரின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது. எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர் தம் குடும்பத்தினருக்கும் அவர் தம் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தனவற்றை மாற்றோம், நல்லவற்றை உள்வாங்கும், மாற்ற முடியாதனவற்றை காரணத்துடன் ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். தேங்க்யூ.
A very warm welcome to all of you. We are very happy to invite all the delegates on the panel as well as who have joined us on the Zoom link for this very important discussion of the pediatric infectious disease chapter. Thank you so much for joining. Now I request Dr. Janani Madam, our chairperson, to kindly deliver the welcome address to all.
Yeah. Good evening, everyone. This will be the first virtual program that will be conducted by the Tamil Nadu ID chapter. We thought we will address the burning issue of that's been going on for the last 2 months amidst pediatricians and pediatric intensivists. So we just thought we'll just give away clear messages to the participants. Thank you all for joining.
Yeah. Thank you, ma'am. I now invite Dr. Vasant Kalatkar sir. Hope he has joined. Now he's not joined. Dr. Suresh Balan sir.
Suresh Balan is also.
Dr. Suresh Balan is just traveling.
I think Balashankar sir is there. He can probably.
Dr. Balashankar sir, President.
Balashankar sir.
President IAP TNSC to deliver his felicitations.
Sir, mute sir.
So unmute and talk sir, please. He's still muted, Narmada.
Oh.
Illa
Unmute.
Sir.
Venkateshwaran sir is also there.
Just tell Dr. Balashankar sir.
Balashankar sir, please deliver your felicitations, sir.
Good evening, everyone. I'm very extremely thankful to IAP ID chapter Tamil Nadu for hosting this timely CME, where the newses are pouring in from all parts of India as well as in Tamil Nadu that the respiratory tract infection is on the rise, and so many children are coming to the OP with respiratory symptoms, and significant chunk of children especially less than 1 year are getting admitted with severe this flu. And still we are, though it has been proposed that H3N2 is the cause. And as far as Tamil Nadu is concerned, there is no much of reports for that. One. Number two, still once again, the COVID is slowly once again creeping inside today. and it is once again causing looming as a big threat. So in this situation, this timing of this CME is perfect, and we should know what is happening in this scenario. And this CME online CME will through prevailing now, and the management issues also which we will be facing as a clinician as well as epidemiologist in this. And I hope this CME will answer so many doubts what we have in our mind. Thank you very much for the opportunity. Thank you, Dr. Narmada and team. Dr. Janani Madam and team. Thank you.
Thank you so much, sir.
Thank you, sir.
Thanks for the kind words. And I request Dr. Venkateswaran, sir, past chair of Infectious ID chapter, to give his felicitations.
Dear office bearers of IAP TNSC and IAP ID chapter Tamil Nadu, a very good evening to all. Before kickstarting this year's program, I would like to express my gratitude and thanks to both organizers and experts who are going to make this program a grand success. And I hope this is going to be one of the excellent and exuberant program of our pediatric medical fraternity. And this will definitely enrich the knowledge and practice, especially in our day-to-day practice. And infectious disease is one of the most commonest problem that we encounter in our day-to-day practice. And this is one of the problem that is being embedded in our daily practice. So enriching the knowledge through our programs in every month. I, as a founder president of IAP ID chapter Tamil Nadu, I welcome this initiative as we together strive to achieve the goal of best knowledge to attain in the area of infectious disease of the pediatric disease. I wish you this program a grand success. Thank you all for the opportunity given.
Thank you so much, Venkateswaran, sir. It was because of your encouragement we were able to do this. And under our presidential action plan, Dr. Janani Madam, we will be having monthly programs routinely from this year onwards. Dr. Tirumurugan, sir, your felicitations, please, while we wait for Dr. Vasant Kalakar to join.
Thank you very much. Let me not repeat what everybody has told, that is going to be a great program and it's a hour of the need. Let me just say that we IAPians of Tamil Nadu, we want to be vibrant and interactive and spread knowledge, and then of course encourage ourselves. In that aspect, in the last EC, we have decided and unanimously and the EC that we should be having more subspecialty chapters, vibrant subspecialty chapters in Tamil Nadu. And in that aspect, the ID has been the forerunner and have already conducted a national infectious disease conference, which is fantastic. And so in this regard, just announcement, which I mean, we have already passed in the EC. I'm just making that known to everybody that from this year onwards, there will be one member from the subspecialty chapters who will represent their subspecialty in the EC meetings as a non-voting member. So there will be more interaction between IAP, TNSC and all the subspecialty chapters. So those who are not into ID, but in whichever specialty chapters, we request them to consider starting a state chapter for their own subspecialties. So thank you very much, and very happy to be here and looking forward for the evening. Thank you.
Thank you, Tirumurugan, sir. That would be a great step towards IAP TNSC, because when I did NCPID, I apparently found that more interaction with IAP TNSC was required. And this will be a great step for us to interact with the EB members of IAP Tamil Nadu. Sir, can you see Vasant Kalakar, sir, on the participants list? And if so, please elevate him, sir. Dr. Sudhakar, have you joined?
I'm just trying to see Dr. Sudhakar and Dr. Vasant Kalakar.
Vasant Kalakar is not there.
No, if he joins in between, I think he can always.
No, I'm just
1 minute. I'm just trying to see.
Sudhakar is also not there. What we'll do is,
Dr.
Narmada,
Sudhakar,
in
can you
between
just
we
raise
can
your
break and do
hand?
it, yeah.
Yeah,
I
there
think
are
yeah,
participants have
there is
raised
one more to this thing. There are 2 people who are raised, so I think it might be Dr.
hands.
Sudhakar. Just promoting.
Yeah, Dr.
No.
Sudhakar has joined.
Now only I got the first panelist. Okay.
Okay. Now, as that Dr. Balashankar sir is there and Dr. PRC sir is there, so I would like to request them to formally inaugurate the microbes while we wait for Dr. Vasankar. PRC sir and Balashankar sir.
Narmada, I think you should share the screen.
Yes, yes, yes. Once sir says a few words, we will.
PRC, sir.
Thanks for the opportunity. Best wishes, and it's very appropriate you are bringing out the microbes also during this occasion. So very happy to be part of this initiative, and very happy also for releasing this current edition of microbes. Best wishes to, and also congratulations to all the people who went to making it, especially to Dr. Sudhakar. Thank you so much.
Sir, ma'am, you can see the this one.
Yeah, I can see.
So we have got the snippets of the important NCPAD key points also in this, along with the articles, which is very interesting read here. And Dr. Sudhakar, can you just say a few words?
Dr. Vasan Kalarkar has just joined.
Yes.
I'm just promoting him as the panelist.
Dr. Sudhakar?
Yeah, I thank for the opportunity to Dr. Janani Madam and Narmada for giving this. And it's a right time we talk about the flu epidemic also. There's an idea of Janani Madam. At the last minute, we added all these things. I thank all the contributors for things. And I hope we are justified for the thing they have written there, because they took a lot of pain to. Thank you every one of the contributors.
Thank you, Sudhakar. Thank you, Sudhakar, for all that hard work.
Yeah. Dr. Vasant Kalarkar, sir, can you please say a few words for this? And we are very happy to have the first academic session, the National Center of ID chapter.
Sure. It's good evening, everyone. Sorry I joined late. And this is like really it's a good idea of microbes and everything. That will add something in infectious diseases. That's a new project by all people. I wish all the best to you all. Thank you.
Thank you so much, sir. Thanks for the kind words.
Narmada, you're muted.
Dr. Rajkumar has not joined here. We can start the panel discussion, madam.
Yeah. Okay. Thank you, all the senior members of the ID chapter for making this inaugurating this event in a grand manner. Thanks to Dr. Vasant Kalarkar for joining from wherever you are. So moving on to the actual panel. So this panel discussion was decided in view of this current epidemic that's been going on. I have with me 5 panelists and 2 experts. The 2 experts are Dr. Padmasini from Ramchandra Medical College. She's the HOD of Ramchandra Pediatric Department of Ramchandra Medical College, Srihar. And she's also has a lot of experience with ID, and she's part of the ID chapter, National ID chapter. And the other expert is Dr. Winsley Rose, again an ID person from CMC Vellore. The panelists, we have 5 panelists. I just chose from different districts, practitioners, people who are having standalone practice, and people who have their own nursing homes, and also an ID person and an intensivist to comprise my panel. The panelists are Dr. Ramanathan, a very, very busy rational practitioner from Trichy, Dr. Thirumurugan, Secretary, Tamil Nadu State Chapter, plus a very, very busy practitioner, and he also owns the Padmavati Nursing Home at Pondicherry. Then we have Dr. Narmada. Again, Narmada is a very, very busy practitioner and director of the Nalam Medical Center at Vellore. Then we have Dr. Dhanalakshmi, an infectious disease consultant at Kanchi Kamakoti Child's Trust Hospital. And also we have Dr. Sendil, who's a pediatric intensivist at Madurai Meenakshi Mission Hospital. So I think that makes the panel complete with all people from different areas. And I've also asked Dr. Kanimori to join. I don't know whether Dr. Kanimori has joined. So in the end, I thought we'll also have a radiologist who will be an expert and share her views towards the end. Okay, so moving on to the, Dr. Nisha. Nisha is the main person who has done this entire PowerPoint. I just gave my thoughts and then she made it into a proper PowerPoint. Thanks, Nisha. And Nisha is again a practitioner at Vellore, and she's also a very, very young and enthusiastic part of the ID chapter. So Nisha will be presenting the case and I will be throwing open the questions to the panelists and the experts. And the disclosure is I have not shared the questions with any of the panelists. It's just going to be extempore that they'll be answering. So over to Nisha. Nisha, you can start presenting. Yeah.
Ma'am, can it have it in a screenshot?
Yeah, I will.
And Dr. Tirumurugan said Dr. Rajendran, the academic coordinator for this 4C, has joined, I think so.
Yeah.
Welcome, Dr. Rajendran.
Dr. Rajendran, sir, welcome.
Sir, you're muted, sir.
Shall we start?
Yeah, I think we'll start.
Just hold on. Just
Nisha,
one second,
hold
Dr.
on, 1 minute.
Dr. Nisha, just hold on. Dr. Rajendran is just...
Dr. Rajendran and Dr. Rajkumar, just...
Yes, respected seniors and dignitaries, and it's my great pleasure to be here. And my best wishes for this program. And already late, we can proceed, please. Thank you, madam. Thank you.
Thank you so much for joining, sir. It's a pleasure that we are having you on board.
Thank you, madam. Thank you.
Thank you,
madam. Sorry to join late, ma'am. Sorry, I was in a
another. Yeah, you can just join and listen and enjoy.
Listen and give the vote of thanks later because we put the vote of thanks for the
when Janani ma'am was delivering the vote of thanks, I joined. Sorry.
Okay, it's okay, Rajkumar. Nisha, you can start here.
Yes, ma'am. So today we'll have 5 cases that will have a complete spectrum of the lower respiratory tract infections in the first ID chapter Zoom meet today. So we'll move on to the first case. The first case is a simple case. It's a 10-year-old boy who has high-grade fever, cough for 5 days, and the clinical examination is very much normal.
Yeah. So this is to Ramanathan. Ramanathan, you have, I think I'm sure you'll be seeing such patients in your busy practice. They just walk in, high-grade fever with chills, and he just coughs as he enters, so you know the complaint. And when you examine him, his throat is clear, his nostrils are okay, and his chest is clear. He's absolutely all right. So what will be your take on this case? Will you just counsel and reassure him, or would you order a CBC, CRP and do an X-ray? Start him on empirical antibiotics because the mother says that he has exams coming in, and would you advise some cough syrups because his cough is troubling him and preventing him from attending his regular school? Over to Ramanathan. Others, please mute yourself, please. Ramanathan, you can start.
Thank you, madam. Thank you very much. Am I audible, madam?
Yeah, yes, you're audible. Yeah.
Oh, this is a very common scenario which we have been seeing in the last months. So we basically have a 10-year-old child with fever for more than 5 days, and his clinical examination is almost normal. So regarding this patient, like if he has been well in the last days and his clinical examination is absolutely normal, like if he's not having any tachypnea and his nose chest signs and no hepatosplenomegaly, I'll just reassure them that my diagnosis will be just a viral respiratory tract infection. Only concern is that he is already into 5-day fever. If it had been a 3 days fever, I would have reassured them. It is almost 5 days now, and I would like to see this child again after 2 days time. So I think there is no point ordering a complete blood count or CRP in this case, because as we see in this era of adenovirus infection, even adenovirus infection has very high CRP and high counts, and if we order one, this may lead to unnecessary prescribing antibiotics for the same.
What about cough syrups? Yeah.
Absolutely. So off late, I have stopped using much of cough syrups, madam. Like only thing is that we have to reassure them, and we have to tell them that cough is a protective mechanism and it should go off in a week's time. I may prescribe some home remedies because there hasn't been any robust studies regarding the use of cough syrup, and most of them are not safe in children. In fact, American Academy of Pediatrics has said no to cough syrups for children less than 2 years. Only one cough syrup has been approved, that too is dextromethorphan at a dose of 1 milligram per kg per dose after 6 years of age. And there is a recent cough syrup, levocloperestin, that has been approved for children more than 2 years. But in this case, I would just like to counsel them and tell them,
Stick
like
to home
previously.
remedies, yeah.
Yes, madam. Previously, the mothers were very insistent that I should write a cough syrup, but thanks to the media and social media coverage reporting the recent incidents, like grave incidents following cough syrup deaths in various parts of the world, like patients themselves are afraid to take coughs, and they ask me if it is safe and if it is really required. That is one good thing which has happened now. So this, going by the epidemiological scenario, this could be a flu or adenoviral infection, but since it is a 5 days fever, I would just do a thorough clinical examination, and in case, and we do a lot of enteric fevers also going on in spite of vaccination. So if he's not having if he's non-toxic and if he's reasonably well in the inbrail period, I will just treat him symptomatically, just give him paracetamol and plenty of oral fluids, ask him to isolate in the house. And as like exams are a concern, but I think this is only a 10-year, he must be in class 4 or 5. He can always take a leave and he can produce a medical certificate. That is not an issue.
Perfect, Dr. Ramanathan. I think all the answers that you said were really perfect. And I think that's the way we should move on. I just want Dr. Padmasani here to tell us some clues from the clinical examination to differentiate viral versus bacterial. Ma'am, Dr. Padmasani?
Yeah, I just want to say at the outset that it is not possible to confidently rule out a bacterial infection based upon clinical features. There are some symptoms and signs which can suggest a viral respiratory infection, such as coryzal symptoms, a respiratory infection with starting with a running nose or a stuffy nose with a sore throat, and if there is multi-system involvement with GI symptoms, and typical pneumonia presents as high-grade fever with productive cough, but atypical pneumonia, you can have low-grade prolonged fever and progressively worsening dry cough. These are some of the clinical symptoms which can differentiate between a typical pneumonia and a bacterial and atypical pneumonia. With respect to laboratory investigations, if you have ordered a complete blood count, polymorphonuclear leukocytosis above 15,000 with a shift to the left may suggest a bacterial infection, but we have to bear in mind that viral infection can also develop secondary bacterial complications. You can get leukopenia in overwhelming bacterial infections as well as in viral infections. Some of the radiological features which can help us. Do you want me to go on, Dr. Janani?
Yeah.
Or do you have that question for somebody else?
No, you can.
Okay. Some of the radiological features which can help to differentiate are that bacterial pneumonia, which is usually because of pneumococcus and rarely because of Staph aureus and Haemophilus influenza, there is alveolar involvement. So you have patchy consolidation or lobar consolidation, whereas in atypical pneumonias and in viral pneumonias, you have an interstitial pattern, which presents as streaks on radiological evaluation.
Yeah, I think that's perfect, ma'am. So the message from this first case is, if you have a child who just walks into the OP with just a fever, I mean, however high the fever is, and if there is a history, family history of other members in the family or other siblings also having some such similar symptoms, doing well during afebrile period, and absolutely normal throat, normal chest, no tachypnea. I think we'll just reassure and avoid cough syrups and avoid empirical antibiotics and avoid investigating if you're confident. I think I like the way Dr. Ramanathan said that I would like to see them in the next 24 to 48 hours. That is what we should do. We can just call them back. We can just tell them because sometimes even adenovirus can cause bad pneumonia requiring ICU admission. So we have to just tell them that even if it is viral, if you feel that the child is very drowsy, or if the child is breathing fast, or if you're worried about any symptom that is worrying you, please report back 24/7. Doctors are available, or you can just call. If you're a practitioner, you can just say that you can just call them and call you up and then come and see you the next day. So that is the message from this case.
2 questions, madam.
Yeah.
One is what home remedies are best suggested? And the other is what is the harm in prescribing a cough syrup or sending the patient without any prescription? Dr. Kamalakan.
Yeah, see, coughs, home remedies, the best is honey and warm water with honey. I think even the PCNA recommends that for a child with cough. Or you can give some milk with boiled milk with turmeric and some pepper powder. Those are the 2 home remedies. They can also use the tulsi concoction or whatever. The harmful effect of cough syrups is most of them are combination drugs, and some of them have beta agonists to that, and some of them have cause a lot of sedation. And we've seen parents, what happens is they have number of cough syrups and they end up giving 5 ml of each. And sometimes when you have a lot of beta agonists, they can end up with tachycardia. And we've even seen SVT in children coming up with a lot of consumption of lot of cough syrups. It makes them cranky, it makes them drowsy, and it unnecessarily causes tachycardia, and it does not control the cough. So that is if there is a wheeze, of course, I agree, you can give a bronchodilator. And I think as Ramanathan mentioned, dextromethorphan can be given if the parents really insist and if the cough is really bothering the child. I think if you just talk to them, spend some time, talk to them, reassure them, ask them to take a lot of warm liquids with honey, added honey, I think they will get convinced. I think if there are no more questions on this.
One thing is, like, is honey really safe?
Yes, it is safe. Good quality honey is really safe.
More than 1 year, actually. When less than 1 year, there's a small risk of botulism. So
yeah, less than 1 year, we don't advise anything. Less than 1 year, I think even the cough syrups, we'll have to be very, very careful. Just ask them to give sips of warm water. And more than 1 year, a good quality honey is safe.
I think this child, ear examination, 5 days fever, we should not miss an OM also. So always look at the ear.
He's a 10-year-old, I think. 10-year-old, yeah, 10-year-old. Smaller children, I agree with you. We have cases coming up, Dana. Okay. So I think we'll move on to the next case. Thanks, Ramanathan. That was
thank you, madam. Thank you for the
answering of
opportunity.
all the questions. Yeah.
Thank you.
Nisha.
Moving on to case 2. Yes, ma'am. Moving on to case 2. We have a 3-year-old girl child who was presented with high-grade fever and reduced activity with cough for 4 days. She looks dull with bilateral crepitations on auscultation. Complete blood counts showed leukopenia with elevated CRP about 96, and chest X-ray showed the following features of bilateral perihilar infiltrates.
Yeah, this question is to Dr. Tirumurugan. Tirumurugan, sir, you have this girl, and how do you proceed? You just reassure, or you order biofire, or you admit and start IV antibiotics, or give oral antibiotics and ask them to review?
Thank you, ma'am. Thank you. Regarding this is probably one of the spectrums which we do see very often these days. And I would kind of go about it in a slightly more staged manner. Let me start with the first part about high-grade fever and reduced activity and maybe cough. In a child like this, what are the cases where I would be worried about, and what are the cases I'd probably be a bit more relaxed? And so definitely if the child has got a coexisting comorbidity, if he's got like diabetes or any of the poor nutrition, malnourished kid, or a child who is immunocompromised. And these days, immunocompromised doesn't necessarily mean they have to have primary immunodeficiencies, but also other cases like chemotherapy, children who receive chemotherapy. A lot of children receive steroids for wheezing, for bronchial asthma or nephrotics, those kind of kids. So those ones I will be extra careful. In addition, I will also look for any red flag signs for any serious bacterial illness. So like a pale looking child, a ill child, a child who doesn't respond. I always feel that if the child smiles at me or if he looks at me and screams at me, I'm more happy than a child who doesn't bother about me. And at any instance, if the child is going to have a respiratory rate of more than 60 per minute, irrespective of the age, we should be careful. Or a child who is just grunting or who is just lying down without having the energy to look around. Those are the cases I would be worried about, and I will be a lot more progressive. And definitely looking at the crepitations itself. See, the crepitations is, in many instances, is though we have always been taught that it has been suggestive of pneumonia, it may not be the case. All it says is there is either the bronchial wall edema or there is extra secretion. So that could be either bacterial or viral, or it may not mean anything. And okay, I probably wouldn't have done a CBC, but having done one and then we have got a...
Oh, the child walks in with the report. Yeah.
Okay, ma'am, that happens very often. It happens. Parents walks in. Yeah. So we have got a leukopenia, and probably it's something very useful to suggest that this is more likely to be a viral, particularly if the child is fairly well. Once the fever is reduced, if the child is looking unwell when the fever is reduced, then I'm in for serious trouble. But otherwise, I would be a lot more in a child who's, once you give some paracetamol and the fever comes down and the child looks active, I would probably think more in terms of a viral infection rather than the bacterial infection. And again, regarding the CRP of 96, it could be, we all know that adenovirus infections, which is rampant right now, can have a very high CRP. It could present with the lobe or pneumonia. So should we go ahead and then chasing it? Personally, I wouldn't consider giving, at least unless the child falls into one of those high-risk categories. At best, I might give a oral antibiotic, either coamoxiclav, being the drug of choice.
Did you order BioFire?
I wouldn't, ma'am, definitely not in place where I work, because see, it's all about saving money, and I think I would love to know the diagnosis, unless but it's not going to change my management of this child. So my procedure, the way I would go about is give them some antibiotics, possibly coamoxiclav or amoxicillin, and then in a well child, and if the child is ill, then consider bringing the child for, particularly if the child has got a very poor oral intake, consider for some IV fluid and IV antibiotics.
Okay.
Thank you.
Yeah, I think that is perfect. Dr. Winsley, would you like to comment on this? Dr. Winsley?
Yeah, I'm just unmuting myself. So, so I mean, I think.
Do you agree with Thirumurugan, or would you like to disagree with him on his points?
So, I think I think first I would require actually more clinical information to actually decide what to do with this child. I think it's a
this is a previously well child, healthy child.
No, I'm just saying that, like, there are certain indicators which might actually give you a clue as to what to do next. I think one of them is presence of chest indrawing, presence of fast breathing. I mean, Dr. Thirumurugan also mentioned about the respiratory rate being more than 60 for any child, but I think for this child, probably a rate more than 40 would still be significant. And the presence of chest indrawing, and looking for danger signs of pneumonia, such as, I mean, you've already said reduced activity, but lethargy, inability to drink, presence of cyanosis. I think these are all important things to look at to actually decide what to do next. Actually, from my perspective, I mean, like if you were to use a stethoscope, it's mainly to look for a wheeze. If there is no wheeze, I mean, that's one way to say, okay, this tachypnea is probably related to a pneumonia rather than just a wheezy illness. Crepitations, I find, is a very, very non-standard auscultatory finding. I mean, some people listen to crepitation, some people don't. So I don't know how useful crepitations are. Bronchial breathing is very useful to listen to, because that indicates consolidation. So I think a little more better, I mean, a full clinical examination and a decision being made on whether this child has got pneumonia with fast breathing or chest indrawing, or a severe pneumonia, I think would be useful to know. And any of these tests, I mean, CBC, CRP, I mean, they are all, nothing distinguishes bacterial pneumonia from a viral pneumonia. Even a chest X-ray, there are some findings which could actually indicate, I mean, Dr. Padmashni also mentioned, I mean, there are some findings which could indicate a bacterial pneumonia, but sometimes it's actually difficult to make a distinction. And mind you, I mean, most often, if you actually look at what decreases mortality with pneumonia, it's use of antibiotics. So I think it's important to determine whether the child is a sick child or not. And if the child has got chest indrawing or fast breathing, or if a child has features of severe pneumonia, requires admission and IV antibiotics. If it's otherwise, I think the child should go on oral antibiotics. I would hesitate not putting the child on antibiotics, given that the child with reduced activity.
Okay. Dr. Winsley, would you also add oral antiviral like oseltamivir, or just add amoxiclav like what Thirumurugan mentioned?
Amoxiclav may not necessarily, I mean, so from the choice of antibiotic, for a pneumonia, I think our biggest etiological agents are, pneumococcus, even if they are vaccinated also. I mean, our biggest worry is actually pneumococcus, H flu, not so much in the post-vaccinated era, and then Moraxella. I mean, most of these, the main thing is pneumococcus. So amoxicillin itself should be sufficient, and I don't think you necessarily need augmentin unless you think that there is staphylococcal involvement. With regards to the oseltamivir, this child is already, it's been 4 days of symptoms. I'm not sure whether using oseltamivir at this stage, even if it was flu, is going to make a difference. But having said that, if the child requires admission, and if the child is, and this is a time when there is a lot of flu, it may be worthwhile adding oseltamivir to this child if the child requires admission.
Can you just tell us the indications, clear-cut indications for oseltamivir? Because I see a lot of children walking into the OP receiving oseltamivir prescription. Can you just, for the benefit of the listeners, can you just tell clear-cut indications for oseltamivir, and then we can conclude this case?
So if somebody has, I mean, I think the one is if there is a lot of flu growing around, and it is at a time when and if it's a child who needs admission for pneumonia, you should start oseltamivir. Okay. If it's OP practice, if you think it's flu, and if it is less than 2 days, it may, I mean, you might want to start oseltamivir in a small child, especially in a less than 2-year-old, or less than 5-year-old maybe. But older than that, I don't really think there is much role for oseltamivir unless somebody is already immunosuppressed. I mean, there was mention of immunosuppression as to whether it could be steroid use, whether it could be PID, HIV, or cancer chemotherapy, or if somebody is on chronic aspirin use. So any of these indications, then yes, oseltamivir. But otherwise, I wouldn't necessarily start oseltamivir if it is more than 2 days in OP practice.
So we'll stick to the category A, B, C, which has been mentioned by the CDC. Yeah.
Yeah. So the difficulty is we don't always have like by the time we order the test and get the result back, it is that 48-hour window is gone. So really, if we want to start, we should start it early rather than late. But if somebody gets admitted, then anyway, they should be started on. Yeah.
Thank you.
There are 3 questions, ma'am. One is already oseltamivir has been asked. The next is, on what day of illness you advise investigation, and what investigations you would advise? And when will you ask for biofire and blood if it is indicated?
We'll answer those in the coming cases. They'll understand that those questions will be answered in the subsequent case.
Yeah, vitamin A on day 1 and day 2 of severe cough or adenovirus, ma'am. And the parent's concern is fevers not responding to paracetamol. What should be the next drug of choice?
Vitamin A, I don't know. That is only when you think of measles. I don't think for adenovirus. And alternative drug for paracetamol, I think if it's an older child and if you're very confident about the educational status of the parents, you can give NSAIDs, but I don't advise mefenamic acid.
Ma'am, role of CRP here, ma'am, and when will you repeat it after a couple of days?
No. CRP, this child walked in with a CRP. CRP is of no use.
Whether CRP will be high in influenza?
Yes. CRP is high even in adenoviral and in other viral infections also. So because the X-ray looks like a viral, and I think Dr. Winsley has really clearly said, Van Thirumurugan have clearly indicated what they would do in each situation of about this child. I think the messages were very clear. You just, if the child is having an underlying immunosuppressed status, or if the child is very ill, I think they will admit and they will give an oral, IV amoxicillin or oral amoxicillin and oseltamivir if they're going to admit the child. I don't think they will do anything else. If the child is otherwise well and if the parents are confident of taking care of the child, probably oral antibiotic and send them out. Yeah.
Yes, sir, ma'am. Any role?
No role. No role for yes, sir. Yeah, I think we'll move on. Yeah.
Yes, ma'am.
Thank you, Thirumurugan and Dr. Winsley, for those valuable inputs for this child.
Thank you, ma'am. Thank you, ma'am.
Yeah, thank you, Thirumurugan. Yeah.
Thank you, sir.
So moving on to Nisha, third
Yes.
child.
Moving on to case 3, Dr. Narmada ma'am. 8-year-old with severe allergic rhinitis who is on preventer therapies. He presents with recurrent episodes of headache and purulent nasal discharge and productive cough.
Yeah, Narmada.
Yes, ma'am. This
So
is,
this is, I think, the bread and butter of all pediatricians. We see day in and day out, every child comes with a leaky nose, cough, and the hypertrophied nasal turbinates and cough. My parents say he's been coughing for the last 1 month. He's been having cough for the last 15 days. And so how do you treat him as ABRS? Would you modify the preventer therapy that he's already on, or would you advise allergy testing?
again, I would take it in steps, ma'am. First is the treating as an ABRS. So first, if you have to think, there are 3 pointers to it. One is if it is more than 10 days, the headache and purulent discharge is more than 10 days, or the new occurrence of symptoms, or the fever is very severe for more than 3 or 4 days, it will make me suspect that there is something else happening other than the severe allergic rhinitis, which is already on, probably the rhinosinusitis. Rhinosinusitis is the commonest comorbid feature, which we will see in the case with the severe allergic rhinitis. So the recurrent episodes of headache and purulent nasal discharge will always make me think for the rhinosinusitis, and treating of it is very much essential, and that too with adequate antibiotic dosage, and for a matter of 10 days, we'll have to see. And if it is going to be recurrent, I would call in ENT surgeon also for the opinion of why it is so recurrent in spite of the good treatment. And then with regard coming to the productive cough, the cough in the sinusitis, it is basically because of the postnasal drip. We can see that as soon as the child lies down, then he has a very much bout of cough. Whereas we also know that 98% of allergic rhinitis are also associated with asthma. Significant amount of children are associated with that. So if the cough is after a little later in the night, and then it is actually early morning, more of early morning and disturbing the sleep, then I would also think whether I should have been, it's a unified airway disease. So whether the asthma part of it is not really controlled, because quite often what happens is if you do not control both together, they have recurrent symptoms, but that is not the case in this case, because there is headache and purulent nasal discharge, more pointing towards sinusitis feature only. With regard to the modifying the preventer therapy, we would see what is more disturbing the child, whether it is the allergic rhinitis component or the rhinosinusitis component. So if the rhinosinusitis component is more, that will require here. Whereas if the allergic rhinitis, the nasal symptoms, as madam told, that they come with the cough, early morning sneezing is more, the hypertrophic turbinates are more, child is also having rhinoconjunctivitis, then definitely it will require with regard to the preventer therapy. One more added point will be there is with regard to the otitis media also. If it is going to be persistent, I will also ask about obstructive sleep apnea symptoms. So 2 or 3 comorbid features are there, then definitely preventer therapy has to be stepped up, as well as control all the other features also. With regard to the allergy testing, yes, I would do, provided I have controlled all the comorbid features, and I would want to know if they can suggest any lifestyle modifications. Because if you see that there are 3 or 4 things that makes the allergic rhinosinusitis, allergic rhinitis and rhinosinusitis also persistent. One is having a smoker in the family, quite exposure to the dust inside the area. All these are factors, and any other like bottle feeding. This is of course an 8-year-old child. In a younger child, I would say these are the features that would predispose them to rhinosinusitis as well as persistent of allergic rhinitis. In that condition, I would also modify the lifestyle modification is also actually required. So this cases, I would step up all this thing, look out for other comorbid features too.
So in your experience, what allergy testing, what common allergen have you found?
Ma'am, most often it is the indoor allergens. The one thing is, I would find mostly less than 5 years if I do, it's mostly only viral induced yeast. And there is a history of smoking in the family. And especially in my area, the grandfathers are the major problem, because this BD workers are there more. They inhabit with the child while the parents go out. So that is one thing, smoking history. But if I have to do allergy skin testing, it is most of indoor allergen. Predominantly, it is the dust mite which I do, ma'am.
Dust mite, yeah. That's why we always tell the parents that usually it's dust mite and keep the house clean. Yeah, the pillow covers.
Wet mopping is advocated. Another thing is washing the bed sheets of the child and removing the fur toys and carpets, washing the bed sheet at 55 degrees. That is, it's in a hot water, and as well as you have to dry it also in the sun dry. So these are the two things. Wet mopping is very much essential, because they use the vacuum thing, or they use freshness, air freshness. Both are not useful. So we have to use the wet mopping as very much. And with regard to there are some evidences which say that encasing of pillows and mattresses have helped, but we are not yet got the final answer for that.
What about pets, contact with pets, birds, lovebirds and pigeons?
Well, the pets is very difficult, ma'am. Dogs actually are, there are certain variety of dogs, like the Indian breed is very much protective. Whereas if you have the dogs with the furs, it is not there. And especially if the symptoms are worsened after the appearance of pets, then we would think about that. And with regard to the cats are a ubiquitous antigen which is present there, and they may even if the cat is removed from the house 6 months later, or till 6 months, the child can have symptoms. So if they are suspicion, they are saying that cats are frequenting the house, then the allergy testing will help. But especially we'll have to do with the pets which they're just co-inhabiting with the family. The best thing is keep the pets away from if a child is allergic, away from the beds and the places where the child is there. It is preferable to keep out. With regard to the other pets like birds, especially some birds are allergenic, whereas some do have too predisposed to Th1 immunity. It is also a protective factor. So pets on an individual case basis, we can take it out now.
Okay, thank you. I think Winsley Rose or Padmasani ma'am, you want to add anything to whatever Narmada has told? Anything else?
I just want to add that there is no role for ordering an X-ray PNS. It is of
yeah. We never do that. We never do
that. Clinical diagnosis.
Yes,
clinical only, ma'am. Only ENT opinion suggested.
And water's view is the most difficult thing for the child to get. If you order an X-ray and water's view, it's very difficult. You have to lie down in a prone position. We never order sinus X-ray. It's a clinical diagnosis. We have clear-cut Infectious Disease Society guidelines for criteria for ABRS and allergic rhinitis management. I think Narmada has clearly told whatever has to be done. Dr. Winsley, you want to add anything, or should we move on to the next case?
I think you can move on. I have nothing else to add.
Yeah.
Ma'am, there are 3 questions, madam. Does intranasal corticosteroid help in all cases of rhinitis, irrespective of allergy status? I don't think so, ma'am. If there is an
you have to answer that. Yeah.
If there's an allergy component only, we would go for that one. So that's what I said. We have to evaluate the child completely. And if there are other comorbid features, that becomes a priority. When the allergy component is more, intranasal steroids will be helpful. And one have commented that dust mite and cockroach. Yes, we do see cockroach, but dust mite comes as a priority. And what drug is commonly used in allergic rhinitis age-wise? Like mometasone is the one we use less than 2 years, ma'am. With regard to above, we use the other thing. With regard to the combination drug with azilastin, we never use in pediatric age group. And what percentage of allergy is prevented by allergen avoidance? That naturally allergic rhinitis, the person allergic, there's a significant number. It's not like percentage. Lifestyle measures, treating of the underlying condition, lifestyle modification and intranasal steroid together only act in controlling the allergies.
Yeah, agreed. Totally. Just not only the drugs, I always tell my parents, it's not only the drugs that is going to help, you'll also have to listen to whatever we say. As you mentioned, if it's a smaller child, avoid bottle feeding when the child is sleeping, avoid lying down and feeding in the nights, and keep the house clean, avoid, close contact with pets. All that I think we keep repeating to all these patients with allergy. I think we have seen an increase in the numbers of children with allergy. I do not know whether it is the polluted atmosphere or whether the AC air conditions that is being used in schools, that is the other reason. Most of the schools in Chennai, they have the schools use air condition. I'm not sure whether they clean the filters. That's again another reason for the increase in the numbers of allergic rhinitis that we are seeing in the last few years.
Just to add on, ma'am, for this
Yeah.
this 1 month, those children who had come with recurrent allergic rhinitis, I did do an allergy skin test for more than 20 children who offered voluntarily to do that. And to be surprising, before and all, I used to find a lot of dust mite and cockroach, but this season, their sensitivity to dust mite and cockroach was very less. Probably it was all viral induced only, ma'am. This is
Viral
my
induced,
observation.
yeah.
I'm just
This-
waiting for more number of cases to publish it.
Yeah, this season I think it's all triggered by viral. Yes.
Probably
Okay.
rhinovirus, we think of RSV, but rhinovirus is more commonly rhino and adeno and influenza can predispose them to allergic phenomenon too.
Okay, thank you, Narmada.
Thanks,
We'll
ma'am.
move on to the next chat. Yeah. Nisha?
Yes, ma'am. Moving on to case 4. Here is a 3-year-old previously well girl child, who has already been given pneumococcal vaccine. She presented with fever and cough for 10 days. The chest X-ray shows right lower lobe pneumonia. She was admitted and treated with IV ceftriaxone for 4 days and then to oral amoxiclav. The blood cultures were sterile and she was readmitted for 3 days later after discharge for persisting fever spikes. This was the X-ray taken on 27th February, and the next X-ray which was taken after a week on 6th March.
So this question is to Dhanalakshmi. Dhanalakshmi, this is a child which I already discussed with you about this child. The first admission itself, she was a very well child who's been vaccinated from an upper socioeconomic status. Vaccinated child came with if you see the X-ray, with a very small evolving patch on the right lower lobe. So parents were very anxious, high-grade fever, so admitted and treated with parenteral ceftriaxone for 4 days. Became afebrile in the hospital, discharged home on oral amoxiclav. Was well for 3 days after discharge, readmitted with high-grade fever. Repeat X-ray shows worsening of this pneumonia. So parapneumonic effusion with septa and biofire was ordered, Corona OC 43. It required ICD introduction by the surgeon. How do you really explain this, and how do you talk to the parents and convince them? Like, it was very difficult for me to talk to these parents and convince them while, on antibiotics, why is she deteriorating? Your comments, Dana.
Yes, ma'am. Ma'am, this is a child with the right lower lobe pneumonia. In the X-ray, there is a peripheral consolidation. Usually, the traditional teaching is whenever you see infiltrates close to the hilum, that is perihilar, parahilar infiltrates, it favor a viral etiology. Sir, the X-ray shows typically the peripheral consolidation. So most likely, as sir initially pointed out, the most common etiology is pneumococcus. And since the child was hospitalized, I assume this is probably a severe pneumonia, must be having signs of severe pneumonia. So given ceftriaxone, once the fever settled down, the child might have probably discharged. But in the pneumonia, the complication is always the disease progression, rather than it is not the improper choice of antibiotic or it is a drug resistance. It is the original disease process as a complication of the disease that is responsible for the parapneumonic effusion. And the repeat X-ray, there is a definite worsening. That is the lower lobe and middle lobe consolidation. But definitely you can see a fluid. And the diagnostic pleural fluid which shows the parapneumonic effusion, hence ICD was inserted. And depending on the comment on the biofire report, so this child, we have a clear diagnosis of bacterial infection. I don't think here we should not have done a biofire for this child. So biofire usually, even if it is a viral infection starting with complication, secondary bacterial infection, which happens usually after 5 to 7 days, nobody will be able to clearly differentiate which one is viral. Like sometimes we rarely encounter adenoviral infection with parapneumonic effusion, or it is an adenoviral or influenza with secondary bacterial infection. It is very difficult to differentiate. So at this point of time, doing a biofire may not be indicated. And with interpretation of the biofire report, they always say, if you pick up influenza, parainfluenza, RSV, human metapneumovirus, they are suggestive of acute viral infection. The other viruses you pick up may be a colonizer or it may be a long-term persister. It is very difficult to say which one is responsible for the current illness. And the biofire, this Corona OC43, this is long time here. This is a non-SARS-CoV-2 coronavirus. It is commonly implicated in upper respiratory infection. it is usually not causing lower respiratory infection. So that is not the etiological agent. So here I put my money mostly on pneumococcal pneumonia with complication.
Agreed.
Choice of antibiotic, once there is an effusion, we always try to cover pneumococcus along with staphylococcus. So if there is look for clues for staphylococcal infection, if there is a skin infection, or if there is an empyema, definitely we will try to cover for staphylococcus also. And depends on the area where you are practicing. If it is MRSA is more, along with ceftriaxone, you add clindamycin. In your area, if the MRSA incidence is less, maybe amoxiclav may be good enough drug.
Okay.
To cover only MSSA.
Yeah, agreed. This child was started on ceftriaxone and clindamycin during the second admission. Clindamycin was added, and ICD was introduced. 2 doses of streptokinase was 3 doses of streptokinase was given, and she improved really well and was discharged again on oral amoxiclav. Ideal oral switchover drug. There's again a lot of confusion when you start the child on ceftriaxone. People prefer to sometimes change over to cepoderm and cefpodoxin or amoxiclav. Which do you recommend?
If there is a strong indicator for a staphylococcal pneumonia and culture has not grown anything, I think it is an MSSA. To cover pneumococcus and MSSA, I prefer amoxiclav more than cefpodoxin.
And what about this cloxacillin that is newly available now? Cloxacillin syrup is available now.
Yes,
do you
ma'am.
advise oral cloxacillin syrup as a follow-up therapy, as a switch therapy?
If it is a confirmed diagnosis of MSSA, then we can follow it up, ma'am.
Okay. Otherwise, amoxiclav is the better drug.
Amoxiclav is better, ma'am.
Better. Cepodoxin, you don't advise.
Cefpodoxin for a plain pneumonia without effusion. Once you are given ceftriaxone to switch therapy as once you discharge, then you can consider cefpodoxin.
But not for complicated pneumonia.
Not for complicated pneumonia.
Okay. Dr. Padmasini and Dr. Winsley, would you like to add anything? Dr. Winsley?
Yes, I also do not approve of cefpodoxime as a step-down oral drug. It is got a broader spectrum. When you have amoxicillin or amoxiclav available and you're reasonably sure it's either staph or step, they would become the first choice of oral step-down antibiotics. The other thing which we have to tell children with parents of children with pneumonia is that pneumococcal pneumonia and staph pneumonia are notorious for developing pyogenic complications. So they should be aware that there can be a recurrence of fever and there can be, in spite of appropriate treatment, the right dose of antibiotics and the right route of administration, there can be complications and we will have to watch out for it. It should not come as an unexpected shock to them that, in spite of treatment.
Yeah, I think we should counsel them adequately even
At
during
the time
the
of
first
diagnosis,
admission.
we will tell them that these are the complications.
Yeah. Dr. Winsley, can you just, add a few points about this biofire? Because what is your take on this biofire indications, as well as how do you interpret when you have these? Are they really sensitive? What is the sensitivity and the specificity?
So I think the one thing that we need to remember is pneumonia is an infection of the lung parenchyma, and biofire, the sample that we take is actually from the nasopharynx. So whatever is there in the nasopharynx doesn't necessarily correspond to what is there within the lung parenchyma. So I think so that's why was mentioned, a lot of the viruses just hang around in the nasopharynx and
colonizers,
they're just seasonally there and then they go away. The one thing, the few things where there may be a difference is RSV. RSV is one thing where if you find it even in the nasopharyngeal swab, that is a real thing. Sometimes even flu and all tends to hang around, but was mentioned, it's not, Dhanalakshmi mentioned that flu, paraflu, human metapneumovirus, these are all more likely to be pathogenic rather than just commensals, which are in this thing. But RSV is one thing which will definitely be there. The other thing where the biofire can help, is pertussis. So the parapertussis, pertussis, mycoplasma, these are also there in the biofire. And pertussis, if you actually pick it up from the nasopharyngeal swab, that is pertussis. There is no colonization. So I think that is another area where the biofire might help. I've actually in the last month, I had 2 children with pertussis, and we do a pertussis PCR itself. And we actually, both of them are pertussis PCR positive, all newborns, I mean, about 35-day-old babies. So I think if we remember that BioFire is a nasopharyngeal swab, and it does not necessarily reflect what is there in the lung, I think that's a useful thing to do. And BioFire is very expensive. I don't know whether we don't do BioFire. We actually do multiplex PCRs, which actually cost about 3,000, 4,000 rupees. I don't know, but the BioFire costs about 10,000 rupees or
Yeah,
so.
it's about 12,000.
Yeah. So
we also do it only in ICU. I mean, very sick children in the ICU, they do. We don't do it outside.
Yeah, because in our multiplex, we also have adenovirus. So everything is there in our multiplex, so we don't really use the.
So the message is BioFire is not indicated routinely unless the child is very sick, and take the reports with a pinch of salt. You don't have to think that all of them are pathogenic. Most of them are colonizers, except for flu, para-influenza, and metapneumovirus and RSV. Others are usually colonizers. Is that correct?
Yeah, I think that's fair to say. The other thing which in this particular case, what we would have done would be to actually do a strep pneumo, either a PCR or a latex agglutination test on the fluid that you get out of the ICD. That might give you a clue as to what it is.
This fluid also did not grow anything.
It doesn't grow. Culture doesn't grow because the child has already been on antibiotics.
Yes,
but if you do an antigen test or a PCR, you might pick up. Because actually, if you actually look at studies which looking at pleural effusions, if you look at studies done in the West, the commonest cause is strep pneumonia. But if you look at studies done in India, it'll always be staph aureus, because strep pneumonia is very, very it gets killed off very quickly, and you don't isolate on culture, unlike Staphylococcus aureus. So if you do antigen tests or PCR, you might pick up the pneumococcal antigen or PCR. And I totally agree that you need to cover Staphylococcus aureus when you
when you have an effusion, we always cover.
Ma'am, the question is, for a BioFire, do you take a nasal swab or the oropharyngeal swab?
Nasopharyngeal.
And the thing is, they have asked all the experts, what is the panel's experience with regard to persistent bacterial bronchitis?
Persistent. I think Dr. Winsley can answer that.
Actually, I must confess, I don't know what that is. Persistent bacterial bronchitis. I am not sure. I don't know whether it means. I'm not sure, because I don't think that's a term that we use in children. I mean, I'm sort of scared.
Protracted bacterial bronchitis.
Protracted, yeah.
It's not persistent.
Same thing. If it's there for a longer time, it's called persistent bacterial.
Dr. Ramnath, maybe you can answer. I don't know.
That is more than 4 weeks of wet cough. Child is presenting with more than 4 weeks of wet cough. They require a course of amoxiclav for at least a period of 2 weeks. That is one entity. 2 weeks. Amoxiclav for 2 weeks. That is PBB. Protracted bacterial bronchitis.
Persistent bacterial.
And otherwise, child is well and not much of fever. They may have some chest signs.
Padmasri ma'am,
I think it's 3 weeks rather than 4 weeks.
21 days is what I was thinking.
Yes. No, we have to confess that the clinical criteria are non-specific. And we have to have criteria to diagnose to avoid the overuse of antibiotics. It is a differential diagnosis for asthma. So when you are suspecting persistent bacterial bronchitis, you treat with a prolonged course of antibiotics, 3 to 4 weeks.
And
this came from the Europe. I don't think we have had any other country talking much about persistent bacterial bronchitis.
Yeah.
Ma'am, on the same note, should we look out for any anatomical anomalies in this particular case where we have in a normal child?
Yes. Any child with persistent respiratory symptoms or recurrent respiratory symptoms, you have to rule out anatomy.
Immotile cilia syndrome and other things have to be looked at.
Yes. I mean, the differential diagnosis is long and we have to proceed systematically.
Yeah.
Ma'am, this has been asked for Dana ma'am. Why didn't you start the child on Piptas and Clinda, and what is the role of Azathral in this case, because for the second admission?
No one asked added Piptas. Who gave Piptas?
We have not started. Only ceftriaxone.
Ceftriaxone and clindamycin.
Yeah, they are asking why you didn't start on Piptas and Clinda in the first episode.
No, immunocompetent child, gram-negative organisms are not the commonest etiology for pneumonia. So always you think of gram-positive, that is pneumococcus and staphylococcus. Even if there are complications, we need not think about gram-negatives, Pseudomonas, E. coli, Klebsiella, which is going to happen either in infants less than 3 months of age, or you suspect some immunodeficiency, or if there is a cystic fibrosis. Otherwise, most of the time we need not go beyond
Yeah.
For a staphylococcal infection, MSSA or FRSA. That's all.
Two questions on the role of azithromycin in this case, madam.
Azithromycin. So this is a effusion. This is unlikely to be mycoplasma pneumonia. The concept about treating mycoplasma is now changing. In fact, treating macrolide is also
Macrolide resistance is going up. Yeah.
Going up, and the severe pneumonia due to mycoplasma. Now they are suggesting some other immunomodulation, including steroids, IVIG. The process is going on. So I don't think routinely.
This child doesn't look like mycoplasma.
No, they have
and no extrapulmonary manifestation also to think of mycoplasma in this child.
Ma'am, there is you mentioned about necrosis in the slide. Should we go for higher antibiotics if it is necrotizing pneumonia? If so,
even if it is a necrotizing pneumonia, the commonest etiology is only pneumococcus and staphylococcus.
And why we did not use a combination of vancomycin instead of ceftriaxone?
Vancomycin is indicated only if there is a bacteremia. Or if there is an endovascular infection suggestion. Child is long term in ICU, you have a long central line. If there is a strong suspicion of endovascular infection or the child is hemodynamically unstable, you may suspect a bacteremia. In that scenario only, you have to use vancomycin. The problem with vancomycin is the lung penetration is not very good as compared to clinda or linezolid. So that is why in a stable children like this child is sick in the sense only respiratory.
Yeah, she's not clinically not sick. Only the X-ray progress. That's all.
Only respiratory wise the child is sick. So you need not use vancomycin for this child.
Should we consider any rheumatological causes in this case?
Hey, Narmada, I think we'll close this case.
No, ma'am.
Yeah. No. Dana, please. I think we are going beyond. Out of. Yeah, I think we've finished all questions pertaining to this case. I think we'll move on to the next case. Come on, Nisha, the next case.
So the last case, 3-year-old previously well child with fever, cough, and cold for 3 days and lethargy for the last 1 day. And admitted outside with hemoglobin of 9.4, total count of 500 and platelet of 1.32 lakhs with CRP elevated around 240. Admitted on 28 February with severe hypoxemia, around 63 was the VO2 and saturation of around 85%. Child was receiving vancomycin, meropenem, and venturi mask. Was put on day 1 at PICU for viral pneumonia with ARDS.
So this question is to Sendil.
Yeah,
Sendil, this is our own child who was in the ICU. I would like you to comment on this clinical picture, the labs, as well as the X-ray.
Previously well 3-year-old child has now presented with fever, cough, cold, respiratory distress with impending respiratory failure, with an investigation of an anemia, severe leukopenia, and then borderline platelet of 1.3 with high CRP. And the X-ray was showing bilateral consolidation involving both the right lower middle and the left middle and lower lobes. This is the scenario the child came in with, and child had been started on the maximum oxygen support. It was mentioned venturi. I would have given an high flow nasal cannula or an NRM mask to start with, and child had been intubated, which denotes the child was very sick respiratory wise. And antibiotics started were Vanco and Miro. And this was the antibiotic the child was started on, and child had been on ventilation. So this is the current scenario we have before us. And the biofire rightly was done because child was sick and intubated, so we could get an organism. And the organism is adenovirus. With the antibiotic coverage, the child improved, and day 7 has been extubated to NIV and has been given steroids also for ARDS probably. And since the cultures were negative, maybe after a 7 days course, the antibiotics were stopped. And there was some right ventricular dysfunction, which was treated with milrinone and which resolved later. So this was the scenario. And the questions posted were comment on the X-rays, viral, bacterial, or viral. I think all the panelists before me have very well addressed the differences between viral and bacterial on an X-ray. And I'm just reinstating that it's very difficult to differentiate a viral and a bacterial. And being provided with such a bad scenario, it doesn't matter whether it is viral or bacterial, we are going to start antibiotics anyway. And regarding the choice of antibiotic, I look at whether this is a single organ system, whether it is a respiratory alone or the respiratory is a part of the multi-organ dysfunction. Since a child was sick, I look at the other organ systems and other features of failure like shock. So if probably the child was in shock, then I would have been justified in starting such an higher antibiotic using Miro and Vanco. If it was a single system like in respiratory, then I would have gone with an ceftriaxone plus clindamycin as Dr. Dana suggested. And that was regarding
this child was also had shock.
Yeah. So that would have been the reason that vancomycin and bigger guns have been used. So that's regarding the antibiotic choice. It all depends upon whether the child has a single organ or a part of a multi-organ.
Agreed.
That decides your antibiotic choice. And then the role of steroids. Yes, any child on ventilator with an ARDS, even though the consensus doesn't give us a clear-cut idea whether to use or not, we intensivists in a state of ARDS, we tend to start steroids early with antibiotics plus or minus antiviral depending upon the scenarios. So whether steroids were right in starting, yes, we would have done the same. Steroids would have been started in any child with ARDS. And should we check for underlying immunodeficiency? This child almost had a bicytopenia. And at this point of time, I would place my bet on the antibiotics, wait for the child to get better. And if the child is not improving both clinically and the numbers wise, then I would have thought about an immunodeficiency workup, but not at the early stage.
Yeah, usually the immune workup during an acutely ill child also is not very conclusive.
Yes, ma'am.
Yeah, I think I mean, how often do you see such, children in your practice in this season?
Yeah, we do. Right now, we have a child who came with a cough, fever, cough, or similar scenario, 3-year fever, cough, cold, with bilateral crepes on oxygen. And initially started on ceftriaxone, and we sent a routine blood culture, and the counts were like platelet was less than 1 lakh, hemoglobin was around 7. And initially we started on ceftriaxone, and surprisingly it came as Klebsiella pneumonia, which was pan resistant. And then we had to hike up the antibiotics. So not very common, but rarely we do face this scenario at the outset now. But this is not the common scenario.
Yeah.
So a single organ respiratory, the choice will be with ceftriaxone, depending upon the severity, plus or minus clindamycin.
Yeah. Dr. Winsley, thanks, Sendil. That was a very clear answers to the questions raised. Dr. Winsley, my question to you is what's happening? Why is this epidemic that's going on so badly? We've never seen such bad viral epidemic in the months of January to March. Do you have any explanation or theories for this?
I must say, these are my own theories. I think it's probably because over the last 3 years, with COVID and all the social
Do you
isolation.
think it's because of the children were not vaccinated?
No, I don't think it's the
COVID?
vaccination. No.
Yeah.
I don't think it's the vaccination. It's just that the last 2 years, they didn't have so many infections. So you probably need some infection every now and then to actually keep your baseline immune status up, so that when you have
hygiene
a
hypothesis.
virus, some amount of infection is required. Because I mean, even if you look at COVID itself, people who are vaccinated and then got the infection, their antibody levels are very, very high. And so much so that even if they get another infection, they don't become sick because of those infections. I mean, they might get the infection, but they don't become really sick with it, which is what I think has happened here. Because over the past few years, people have not had these infections. And suddenly, after the gap of 3 or 4 years, you get an infection, you probably don't have that much immunity to actually withstand this infection. So I don't know. Anyway, that is my.
Do you think we should advise masking and hand hygiene should be promoted again?
No. I think hand hygiene definitely yes. I personally don't believe masking is actually that very important anymore, especially when it comes to children and their social interactions and everything. I think the benefits of masking, I don't believe will I mean, benefits of.
Do you all wear masks in CMC Vellore?
So we don't necessarily wear masks, but a lot of people do. Till recently, there was this thing that actually the hospital policy was to wear a mask. But now, after the last 2-3 weeks, that's been taken off, but some people do. But hand hygiene, I think, is much more important than masking.
Than the masking, yeah. Okay.
I mean, I just want to comment on this particular case.
Yeah.
One thing where, I mean, this is probably a very short illness. It's only a 2-3 day illness. It's probably a adenoviral illness. But in a child, maybe if this child had come with a little more protracted illness, like, 5 to 7 days of illness with a low platelets coming with severe ARDS, it could very well be scrub typhus.
Okay, yeah.
So
agreed.
that's something to keep in mind. And add empiric doxycycline if this child were to come a little bit later. That's the only thing I would add. Yeah.
Agreed. So, any questions on the chat box? I think I'll ask Dr.
There are 7 questions, ma'am. Please.
Yeah. In the meantime, 1 minute. Tirumurugan, can you just make Dr. Kanimori also to share the screen? She's there in the panel list. I think she's there.
Just 1 second, ma'am.
Yeah, I mean, Narmada, you can start asking the question.
She's not in her screen name, ma'am. So it doesn't look like
she's not there.
No.
Hello, ma'am.
Yeah, Kanimori is there. Are you in the panelist list? Panelist group?
Sorry, what's her screen name, ma'am?
Kanimori.
Kanimori or Kani Veins in either of those.
No, she has used your thing. She's in Janani Madam's name, Dr. Tirumurugan, sir.
Oh, no, then, okay.
You can rename yourself, madam.
Okay, sure.
Just 1 second, then I'll make.
Yeah, in the meantime, you can ask the questions.
Yes, ma'am, can I ask Dr. Padmasini, ma'am, could oseltamivir be used in this child, ma'am?
We are talking about clear-cut indications for oseltamivir. If you are suspecting category C and category B influenza, you have to use oseltamivir. So any severe pneumonia in this season using oseltamivir.
You can give oseltamivir for this child.
It is rational, yes.
Yeah. Before the biofire report comes. If after the biofire, there's no point.
You can stop.
Once it is adenovirus, there is no rule. Yeah.
Yes, it helps in influenza A. Yeah, it helps in influenza A, both H1N1 and H3N2. It doesn't help much in influenza B.
Ma'am, they have asked one case, 3 months old child presenting cough and fever for 4 days, X-ray showed lung collapse, and they did intubated with worsening distress, started on Piptas Vanco, child again after 3 days, child again developed severe respiratory distress, repeat X-ray shows collapse again. So they had suspected cystic fibrosis, but the same lung affected again and again, no intraluminal foreign body. What is the differential diagnosis? Any of the panelists?
Yeah, probably bronchoscopy is required in this child.
Yes, ma'am, exactly. This child should be looked for an airway anomaly, should be looked for causes both intraluminal as well as extraluminal. So requires some bronchoscopy plus and contrast CT to see whether there is some pathology which is obstructing the structural anomalies which is obstructing or the creating problem with the airways.
Yeah.
So as
persistent collapse is always an indication for further evaluation.
Can dengue present with severe respiratory symptoms, sir? Winsley, sir?
I don't think dengue presents with cough and all that. I think, it's a febrile.
No, only fluid overload, they can come with respiratory distress, but not with cough. Yeah.
And what is
there must be something else. So dengue, actually, there's a lot of asymptomatic dengue. So just finding NS1 doesn't necessarily mean that somebody's got dengue. Maybe that person has a respiratory illness.
Co-infection, we've seen a lot of dengue co-infections in this season. Yeah.
And role
that's
of
possible.
Role of IVIG in rapidly progressive pneumonia due to adenovirus and cidofovir also for adenovirus.
No, we've not used IVIG as well as cidofovir.
Padmasri ma'am, you want to add on anything to that?
No, we know that several viruses can trigger an extreme inflammatory response in the body, adenovirus and influenza virus. And steroids have been widely used to treat this inflammatory immune dysfunction that we see in pulmonary infections. We have also used IVIG in children on chemotherapy, immunodeficiency children, where we are a little worried about using steroids. And we have found the inflammatory response significantly getting suppressed with IVIG.
Oh.
I cannot quote this evidence for its use, but it has been used in practice and it has been found to be beneficial.
Ma'am, one of the comments from one of the attendees was like, it's a pancytopenia, very severe presentation. Should we check for ferritin? Could it be HLH? And has steroids improved the HLH?
Initial presentation, we don't normally think of HLH, no?
Yeah, Sendil sir, you wanted to add?
Yeah. As Madam rightly pointed, that was our discussion there regarding the immunological workup. So if the child is not improving, and then HLH comes into our purview, then definitely we'll think about HLH or other immune-mediated response syndromes. So all those things will come once the antibiotic doesn't act, maybe after 3 or 4 days of therapy.
They have asked
we do consider.
The dosage of MPS here, sir, 30 milligrams.
2 milligrams.
It will be like 2 milligram per kg as a loading dose, and then 2 milligram per kg equally divided doses twice a day.
2 milligrams.
It's 1 mg per kg per dose. That dose is a pulse therapy that we don't usually use for ARDS. That is reserved for autoimmune diseases.
Pulse is for autoimmune and rheumatological.
And they have asked, could it be because of fungal sepsis, invasive fungal sepsis, because platelets is low and total count is also low?
Not at this point, with a history of just 3 days without any comorbidities or in a well-thriving child. I don't think fungus is not going to come into a picture for the next 7 to 10 days at all. If at all, it will be a secondary fungal infection, which we'll be thinking about.
The children are coming with persistent cough with very clear chest. Cough is disturbing. What to be done now?
We've already told about that. I don't think we'll discuss again about that.
Ceftriaxone is preferred, and can we use cefotaxime as the first line? Whitsley, sir.
So cefotaxime, we need to give it 4 times a day. Ceftriaxone can be given once a day.
Twice a day.
I mean, once a day or twice a day. I mean, depending upon the weight. So
I would prefer
ceftriaxone. Yeah, I prefer ceftriaxone to cefotaxime because of this. Just about the cidofovir. So there may be some. I mean, I don't know if there's somebody who's come very early in the illness and has become very sick. I think there may be a role for cidofovir. It definitely has a role in immunosuppressed children. But in immunocompetent children, I mean, there are reports to say that cidofovir may be used, but in this case also, you've not used cidofovir and this child has gotten better. So I think we probably need to know a little more before we get it. It's a very, very expensive drug and it's got a lot of significant side effects. So it's not an easy drug to give and just get away with it. Something needs, because this kind of severe adenoviral pneumonias in otherwise healthy children, we are seeing it much more this year than in the past. So I think we probably need to know a little more about that.
The recent outbreak in West Bengal, they have been using, sir. Cidofovir has been used.
Yeah, West Bengal.
If you start early, I think there may be a reason to give it, because if the symptoms are less than 4 or 5 days, and if you make a diagnosis, I would also give cidofovir in a very sick child. Like in this child, if I knew it was adenoviral, I probably would have given cidofovir upfront.
Yeah.
And even IVIG for that matter.
Yes.
Same case.
Dr. Tanu has been using IVIG in Mumbai. Dr. Tanu Singhal, infectious disease specialist.
Yeah.
Ma'am, they've asked if that is the case which they have asked, if the bronchoscopy is not available, what do we do in our setup?
Ask them to refer to wherever it's available.
And
I think we'll close there.
Ma'am, only one question, ma'am. Can nebulization be given in bronchopneumonia where no much of added sound except for bronchial breathing?
Not really. Not really helpful. If they want, they can give saline nebulization. It can help. But if there is no bronchospasm, I don't think there's any point in giving salbutamol.
Okay, ma'am. Yeah, thank you.
Yeah, Dr. Winsley, to wind up, peramivir, zanamivir, baloxavir, are they available or have you used them?
For adenovirus?
For, flu-like illness, influenza.
No, I have not used anything other than
oseltamivir.
Yeah.
Okay, fine. Okay, I think Dr. Kanimuri, can you share the screen? I will stop sharing. I just thought the panel will not be complete if we don't include a radiologist. I think we've never ordered so many X-rays in our practice like what we've done in the last 3 months. So I just thought Dr. Kanimuri can just tell what is her thoughts with the X-rays that she's been reporting every day in our hospital. Dr. Kanimuri is a radiologist and a sonologist of Kanchi Kamakoti Child's Trust Hospital. She heads the department. Kanimuri, yeah.
Yes, thank you for inviting me to attend this. So as the previous speakers have all said, it's not always possible to differentiate between bacterial and viral pneumonia on X-ray. But there are a couple of things that may help you point to in one or the other direction. So we'll look at a few examples very quickly. So these are two young children. So on your left is a 1-year-old who had fever, cough for 3 days. And then on your right is an 11-month-old with a similar history. So if you look at the X-ray on your left, what you see here is hazy shadowing in bilateral perihilar region. So these are perihilar infiltrates. And then on the X-ray on your right, what you see is bronchial wall thickening. So if you look closely at the X-ray, you can see lots of ring-like shadows. So those rings are because the wall of the bronchus is thickened, and you see it kind of as a ring, lucency and a white rim to it. So that white rim is a thickened wall of the bronchus. So this is bronchial wall thickening, and both of these are representative of viral infections. So what you're looking for primarily in viral infections are hyperinflation of the lung, bronchial wall thickening, and you may have peribronchial infiltrates as well. So this is a viral infection. So these two X-rays are quite different from the one that we saw previously. So both of these children had high-grade fever for 5 days. And this is typical for a bacterial pneumonia. So you've got consolidation, which is more in the periphery and kind of fading out towards the center. And the sharp line that you see at the bottom is the minor fissure. So this is a right upper lobe consolidation. And on the X-ray on your right, what you see here is increased opacity behind the heart. And if you look at the hemidiaphragm contour, the right hemidiaphragm you can see very well, whereas on the left, the diaphragmatic contour is lost. So this is typical for lower lobe consolidation. So these are typical examples of bacterial consolidation. Now, if you look at this X-ray, you can see features of both. So here you've got consolidation, the heart border is lost. So this is a middle lobe consolidation. But in addition to that, if you look at the rest of the lung fields, you see that there is bronchial wall thickening, and there are also peribronchial infiltrates. So this is a viral with a superadded bacterial infection. This was an 11-year-old who gave a history of fever for only a couple of days. And it's quite apparent to everyone that there are infiltrates in the upper lobe on the left side. But don't mistake this for a bacterial pneumonia. If you look closely at the infiltrates, you can see there are small areas of cavitation within it. And you look at the hilum, you can see that the hilum is being pulled up towards those parenchymal infiltrates. And this is typical for TB. So obviously this must have been going on for a long time. We did go back and ask the patient the history, and they still denied a long history. So in some cases, the patients and the parents may be very poor history giver. Look closely at the X-ray, just because currently we've got this whole explosive pneumonia going on. Don't mistake all parenchymal infiltrates to be a bacterial or a viral pneumonia. We've had a couple of cases of TB in our hospital with a history of just 5-6 days of fever. So always keep TB in the back of your mind. So that was all I wanted to say, but just going quickly to this X-ray of bacterial consolidation. Now, it's very tempting to get a follow-up X-ray after a couple of weeks to see if this is resolved. In children, there really is no need to get a follow-up X-ray. In adults, the reason we do a follow-up X-ray is because the consolidation can mask an underlying lung carcinoma. In children, that is not the case. So you need to go by your clinical features. If the child has recovered, is doing well clinically, there is no need to repeat the X-ray to see whether it's resolved. It makes no difference whether it resolves or not if the child is well. The X-ray features always lag behind the clinical features. So it takes around 8 weeks, sometimes even 12 weeks for the X-ray to clear completely. And if the child is well, there is no need to repeat it. If the child develops recurrent fever or gets better and then again falls sick, then by all means repeat an X-ray. But in a well child, please do not repeat X-rays to see whether it resolves, because even though it's a small radiation dose, at the end of the day, you're still exposing the child and you need to justify the radiation exposure. Yeah, that's all I wanted to share, ma'am.
Thank you. Thank you so much, Kanimuri. That was a very, very clear messages from a radiologist, which made this panel complete.
Thank you, ma'am.
Yeah, thank you. Is there anything else, Narmada, in the chat box?
That's the chat box. They've said that people cannot go with the idea that they should be using IVIG in practice. So I think
No one said IVIG. IVIG is only when the child is very sick having a very severe pneumonia and you're suspecting something like an HLH or something like an ARDS picture, not for all children. No IVIG for normal children with pneumonia.
Can we use nebulization in less than 2 years? Salbutamol, madam.
Yeah, we can use.
Yes.
Use in the correct dose.
Yes, ma'am. That's it, ma'am. For this one, there's nothing. Thank you,
Nothing
Dr.
much.
Ma'am, can she stop her slide?
Yeah, can you stop sharing?
Now I request Dr. Any final word from the panelists, Dr. Padmasree ma'am, Dr. Winsley Rosa, before we conclude the session.
No, we had a very good discussion. Thank you very much for
I think the messages were very clear from all the cases. Do not investigate unless it's really necessary. Do not do X-rays unless you have a child with tachypnea or increased work of breathing, or the child is really disproportionately sick. And as Kanimori said, do not order a repeat X-ray once the child is improved. And do not give oral oseltamivir for children who are treated as outpatients. Follow the category A, B, C for indication for using oseltamivir. Do not use combination cough syrups. If at all you want to give something, you please prescribe dextromethorphan. And please write the dosage clearly, because small infants, we have seen many of them coming very drowsy. And if you look, we start thinking what we are missing, some CNS infection or something. If you look back, it will be a combination of different cough syrups that the parents have given. And about paracetamol is the safest drug for all children with fever in the correct dose. If the parents are very anxious about the temperature not touching normal, you can give them NSAIDs, but give it in the correct dose. Avoid mefenamic acid. I don't think we should give mefenamic acid or combination of mefenamic acid and paracetamol, or combination of paracetamol and other NSAIDs. And I think choice of antibiotics was very clear: amoxicillin or amoxiclav. And admitted children, sick children with bacterial pneumonia, ceftriaxone is the drug of choice. If you have the child developing a parapneumonic effusion, or you have a suspicion that it is staphylococcus, add clindamycin. Unless you're sure that there is, if the child is sick, admitted in shock, in the ICU setup, immunosuppressed with long lines, then vancomycin. Otherwise, I think ceftriaxone and clindamycin is more than enough. And switchover drug is best is amoxiclav. And do not give cefpodoxin if the child has a complicated pneumonia. Switchover drug is still amoxiclav or amoxicillin is better.
Ma'am, can I ask a final word? Padmasree ma'am, is it you're done, ma'am? Winsley Rosa, any final words?
Anything else you want to add?
It has been summed up.
And BioFire, I think BioFire also, I think Dr. Winsley made it very clear. Do not order BioFire in children who are admitted in the ward or outpatients. Reserve it for sick children who are admitted in the ICU, and please interpret it judiciously. Don't think that every organism that you recover from the BioFire is infectious. Dhanalakshmi, you want to add anything?
Macrolide use should be, we have to be very careful while prescribing macrolides.
Yes.
Outpatient prescription contains macrolide. If you look at the pneumococcal resistance pattern, macrolides are highly resistant. So
yes, macrolide is not a choice of antibiotic for an outpatient with pneumonia.
Pertussis, or if you have a strong suspicion of mycoplasma pneumonia, there is no role of macrolide.
No role for macrolide.
No role. IVIG and all the other new antivirals have a specific indications, which is also very clear.
Very sick child in the ICU, you have, consult the ID specialist or the rheumatologist and then decide on IVIG or steroids.
And we acknowledge the presence of Dr. R.N. Sendil and Mohammad Ismail sir, past presidents of IAP Tamil Nadu State Chapter, along with Dr. Kangavel sir, who has always been our patron. Thank you so much for honoring us with your presence, sir.
Thanks to all the seniors who've been with us for the last 1.5 years, bearing with us.
Dr. Rajkumar, can you
Narmada, can I just ask one brief question? Why particular adenovirus is severe in this year? Is it just because we are picking more, or is it because of any other reason?
I think Dr. Winsley explained that very nicely.
Very nicely. That's why I didn't take up that question, sir. He said that it was.
Dr.
Rajkumar sir, can you come for the vote of thanks? And I will also request all the panelists and the people present here to switch on their videos so that I can just take one screenshot.
It's not complete without a picture.
No, it's always selfie is needed. Dr. Rajkumar, over to you for vote of thanks. Please switch on your.
Rajkumar is in the dark.
Rajkumar is again not there.
Yeah, I think.
Felicitations, sir. Kanimori ma'am, can you please switch on your thing, if you can? Yeah. Oh, Ismail sir, thank you. Janani ma'am.
Yeah.
Ma'am, yeah. Sivagurunathan, Amalraj, Tangavil sir, please. Just for a second. Yeah. Thank you. Thank you.
Yeah,
Rajkumar is
has
back.
finally decided to.
Rajkumar has appeared.
Finally, he has decided to honor us with his presence. Yeah. Yes, Rajkumar sir, please go. I took it. I think I have taken.
I think before Rajkumar concludes, I think I should thank all the panelists, the experts, and Dr. Nisha for making this panel discussion a very useful one. I hope we have given clear messages. Pardon us if we cut off some questions, and because we wanted to stick to the time.
Yeah.
Thank you all.
Thank you. Great learning experience. Thank you, madam.
Yeah. Thanks, Thirumurugan, Ramanathan, Senthil, Dana, Narmada, and Nisha, and
I think we
Kanimani.
should give the opportunity to Dr. Rajkumar to thank for all.
I should give a special thanks to Kanimani because last minute I just told her and she just pitched in. And,
wonderful program. The first program for our ID chapter, and it was wonderfully conducted. Thanks to all organizers. Thanks to organizers and all panelists, ma'am. It was a nice program. So many questions. Now we had so many doubts in our mind. All were we are cleared. I thank Dr. Vasant Kalatkar, Chairman PADA, who came. He joined the program, and Dr. Venkateswan sir, and our IAP, Tamil Nadu IAP President sir, and all those people who joined. And I would like to express my thanks. Thank you, one and all.
Should thank Sudhakar also for the timely release of the microbes.
Microbes, yeah.
Thanks, Sudhakar. Yeah. So the microbes carries tips for managing children with respiratory infections during this epidemic. We've added some tips to the practitioners. Kindly go through the microbes. Narmada, you can share the soft copy in all the groups.
Yes, ma'am. Thank you, ma'am. Thank you. And ma'am, as told, along with the inauguration, completed in 9:37. Only
9:37.
So by madam standards, that's 7 minutes later.
That's 7 minutes later. I know.
7 minutes is for Narmada's agenda for inauguration. But we finished the panel on time. Thanks again to everyone. Thank you.
And then we'll see you again the next.
Thank you.